This presentation is based on the patent application number 433 Delhi 2015 with prior permission of the inventor Mr. Prakhyat Roop. The presenter is the father of the inventor. This device has not yet been clinically used. Many inventions of modern medicine have contributed in improving the quality of human life. But IOLs have been one invention which has beneficially affected the highest number of people. Several generations of people have enjoyed the fruits of this invention. However, after more than 6 decades of refinement in design and technology, following needs are still unmet by the present day IOL. Misalignment of visual axis of eye with optical center of IOL because of angle kappa, negative dysphotopsia, absence of any visual clue during surgery for surgeon to be guided about position of optical center of the IOL, and formation of after-cataract. The inventor analyzed that some of these deficiencies are a result of putting a perfectly round IOL in the eye which is neither anatomically nor functionally symmetrical. Anatomically, the anterior vertical corneal diameter is less than its horizontal diameter. Pupil is placed nasal to the center of the cornea. Even in this nasally placed pupil, visual axis passes through a point placed further nasal to the center of this already nasally placed pupil. The retina also extends more to the nasal periphery of the globe than temporal. Similarly, if we analyze the function, field of vision is horizontally bigger than vertically, and even in horizontal axis it extends more temporally than nasally. Present invention challenges the shortcomings of putting a perfectly round IOL in an imperfect sphere. First time ever, the inventor has conceived an IOL with an optic which is an ellipsoid. Its horizontal dimension is more than its vertical dimension. It has two haptics of same size and shape, but these are attached asymmetrically in relation to the central vertical axis of the optic. It has a central ring which is concentric to the optical center of the IOL. This ring is formed by projection of central 3.5 mm diameter of optic on the back surface by 5 microns in this portion of the IOL. In one of the periphery of the optic, there is a small mark which identifies the side of optic which extends to the most peripheral aspect of the capsular bag once IOL is implanted. When IOL is implanted into capsular bag, it is so positioned that haptics are vertically oriented, thus ellipsoid shape of the optic matches with our visual field. Because of the asymmetric placement of haptics on the optic, it automatically settles eccentrically in the capsular bag. Peripheral mark identifies the part of optic which should occupy the nasal aspect of capsular bag. Eccentrically placed optic has two functional benefits. First, it compensates for positive angle kappa by bringing the optical center of the IOL, which is also the geometrical center of the optic, nearer to visual axis of the eye, which passes nasal to the center of capsular bag. Second, more peripheral extension of optic on nasal aspect ensures that even the most peripheral rays of temporal field pass through the optic of IOL, thus completely eliminating negative dysphotopsia. In patients with negative angle kappa, rotating the IOL 180 degree upside down will compensate for negative angle kappa. As surgeon has a visual clue in the form of a ring which is concentric to the optical center of IOL and haptics are asymmetrically placed, surgeon can compensate for angle kappa by rotating IOL in different axes and leaving it in the axis where corneal reflex is best centered within the ring. Thus, even in absence of preoperative assessment of angle kappa, good centering can be achieved during surgery by customizing the axis of placement of haptics for every eye. The added advantage of this ring is that it acts as an additional barrier to the migration of lens epithelial cells to the center of the visual axis. It delays after-cataract formation in visual axis. This projection does not in any significant way interfere with the quality of vision. This projection on the back surface is made oval instead of circular in toric IOLs. The longer diameter of this oval is in line with the peripheral toric marks. This helps in not only providing a clue that particular IOL is toric during surgery but also in post-operative follow-ups. It can be of immense help in aligning the toric IOL to corneal marks in patients with small pupil when peripheral marks are hidden behind the iris. Moreover, the ovalness of this projection can be increased with increasing toricity of the IOL to give a clue to the amount of cylindrical power of the lens. To summarize, the inventor is challenging the status quo by bringing a novel concept of IOL design which fulfills four unmet needs of present-day IOL.